Good evening, friends. Feels nice to meet you all after a gap of 2 weeks. 1 week of Diwali holiday, and last week I was in Hyderabad for a training of some insurance company. So let's begin our journey. We had stopped at miscellaneous lab test, indication, interpretation. So today will be the final version. Next time onwards, we will start with some clinical topic. So amylase lipase, which is commonly done for pancreatic disorders. So what is amylase? Amylase is an enzyme that helps digest carbohydrates. We know that carbohydrates require pancreatic juice and all the pancreatic enzymes. Most of the amylase is made by pancreas as well as salivary glands. A small amount of amylase in blood and urine is normal. Serum amylase is mainly used to diagnose acute pancreatitis or chronic pancreatitis. There is no other indication. So if you have a patient with severe pain in abdomen, multiple vomits, not able to stop vomit, plus minus fever, then you will order amylase first, or maybe amylase lipase both. Amylase rises first, lipase rises later. Amylase levels greater than 3 times normal are diagnostic of acute pancreatitis. So if the normal value is still 65, 70, 80 in that lab, just by 110, 120, you can't diagnose acute pancreatitis. You need at least 3 times normal to arrive at a conclusion of acute pancreatitis. Lower amylase levels are found in alcoholic pancreatitis, and levels may be normal in acute pancreatitis due to hyperlipidemia or hypertriglyceridemia. So 3 commonest causes of acute pancreatitis are alcohol, gallstone, and high triglycerides. High triglycerides mean they'll be in the range of 700 to 1000. Very high amylase, pancreatitis due to gallstones. Lower than that, maybe 3 to 500 in alcoholic pancreatitis. And due to hypertriglycerides, the amylase may be normal. Amylase levels correlate well with clinical course of pancreatitis. As the pancreatitis gets resolved, the amylase levels will come down. Sorry, the same slide coming again. Lipase remains higher for much longer period than amylase, and if levels greater than 3 times normal are used for diagnosis of pancreatitis, lipase has a sensitivity and specificity of about 99%. So lipase also 3 times the upper range of normalcy, then yes, it is pancreatitis. This is of a use to understand the etiology. Our patients always try to hide the history of alcohol. Lipase to amylase ratio may help to distinguish gallstone-induced pancreatitis and alcoholic pancreatitis. Gallstones cause higher increase in amylase, and alcohol causes higher range in lipase. A lipase to amylase ratio of more than 2 is 91% sensitive and 76% specific for alcoholic pancreatitis, and a ratio above 5, 31% sensitivity and 100% specificity for alcoholic pancreatitis. So if your lipase is 1200 and your amylase is 200, then that is surely alcoholic pancreatitis. You will say, how does it matter to us if patient is hiding? Because we only can advise control of alcohol, because these people, if they continue drinking, then acute pancreatitis can turn into hemorrhagic pancreatitis and may turn fatal. Increased SGPT or ALT to 3 times normal is highly specific for gallstone pancreatitis. C-peptide. Coming to C-peptide and serum insulin. C-peptide is a byproduct of insulin production. The level of C-peptide is a gauge of how much insulin is being produced in the body. We use C-peptide to differentiate type 1 diabetes and type 2 diabetes. When pancreas produces insulin, it releases C-peptide into the bloodstream. Abnormally low amount of C-peptide indicate abnormally low amount of insulin, and that is type 1 diabetes, because in type 1 diabetes, there is deficiency of insulin and you need insulin administration for survival. Type 2 diabetes has plenty of insulin, which is defective. It is not effective. It's not giving its usual effect. Abnormally high amount of C-peptide warn us of could be insulinoma. Normal level of C-peptide may signal that all is well. That means not that there is no disease. Body is producing enough insulin. In a person with diabetes, a normal level of C-peptide indicates the body is making plenty of insulin, but it's not effective. Hence, it is type 2 diabetes mellitus. So, C-peptide we will only do when we are not sure whether it is type 1 diabetes or type 2 diabetes. That means first detection of diabetes in adolescents or maybe early 20s, because there is a maturity onset diabetes of youth. There you will find C-peptide normal. So that is type 2 diabetes of the youth. We will never do it in an adult. So then the question arises that if C-peptide tells me about insulin secretion, why do I not check insulin only? Why check C-peptide alone? C-peptide has a longer half-life of approximately 30 minutes compared to only 6 minutes of insulin. So insulin disappears from the blood faster than C-peptide. Hence, insulin secretion or insulin estimation is not done to diagnose type 1 diabetes from type 2 diabetes. Secreted insulin disappears from blood faster than C-peptide. That is why we check C-peptide and not insulin to diagnose type 1 diabetes. Then serum insulin indication. When do we check serum insulin? Standard insulin test that labs do is positive for both endogenous as well as exogenous. So if a patient is getting insulin injections, it will measure both what the body is producing and what the patient is administering. So it is generally not worthwhile doing it. It identifies insulin resistance. A stage before pre-diabetes is hyperinsulinemia. It identifies that. Hyperinsulinemia tells us that patient's insulin is not effective. There is insulin, but it's not working as it should. It is used to manage obesity. So all the dietitians will always advise serum insulin, fasting and post-lunch, because they want to see that this obese person is pre-diabetic or is hyperinsulinemic or not. Few weeks or few months back, we had discussed how diabetes happens. The first stage is obesity. That leads to hypertriglycerides. That leads to hyperinsulinemia. That leads to pre-diabetes. That leads to diabetes. Where you suspect an insulinoma, you can check for serum insulin, but that goes in the realm of an endocrinologist. For us family practitioners, the first three are important. Then certain patients are hypoglycemic. See, either we decide that hypoglycemia in the patient, you may say that only a patient of diabetes who is on medication, OHA or insulin, can get hypoglycemia. But some patients have a perennial low sugar. So to diagnose the cause of that, we need to do serum insulin levels. And if you're type 2 diabetic who's on OHA is not coming under control, and you want to decide, is it time to go on to insulin or should I still try with additional OHA? Patient is already on 3 drugs. That is the time you check serum insulin to decide that patient has very low insulin. All OHAs stimulate the beta cells to produce insulin. But if there is no insulin being secreted, OHAs will fail. That is the time to shift to insulin administration other than OHA. In Western world, especially America and UK, they only use insulin and at the most metformin. Other OHAs they don't use, and insulin administration protects the target organs the best. So first three and the last one is the important thing for our primary practitioners to check. When can we start insulin? Insulin testing is used to assist. Now that I had given the indication of hypoglycemia, plasma glucose levels below 55, symptomatic or not symptomatic? Mostly symptomatic. We want to know what is the cause. Insulinoma will give high insulin level and high C-peptide level. That means insulin is being produced more, which is causing blood sugar to go down. And that is very likely to be insulinoma. Non-beta cell tumors of the pancreas will have no insulin, low insulin, and low C-peptide. Excessive insulin administration, high insulin levels, and low C-peptide. This is exogenous insulin being picked up. Sulfonylurea and glenide are supposed to be insulin secretagogues. If they are being administered, you will again get high insulin and high C-peptide levels. These two group of drugs will produce insulin in the body, and you will get the same effect as excessive insulin administration. And congenital hyperinsulinism, mutation in insulin secreting gene, high insulin and C-peptide levels. You may take a snapshot of this slide if you feel like it. Using commercial assays, normal fasting insulin levels range between 5 to 15 microunits per ml or 3 to 8 micro international units per ml. But there are more sensitive assays. Normal fasting insulin should be lower than 12. Obese subjects have increased values because obesity and hyperinsulinism go hand in hand, while very high circulating levels are found in patients with severe insulin resistance. Postprandial insulin test results vary by age and are usually measured in milligram per deciliter. Normal results for a 2-hour postprandial test based on age. For those who don't have diabetes, less than 140 milligram per DL. For those who have diabetes, less than 180 milligram per DL. Non-invasive test for H. pylori. I must mention here that this video will be available perennially on YouTube for viewing, because I feel this is important for us to get deeper into our practice. So somebody has requested non-invasive test for H. pylori. I'll tell you what it is and why it is not done and why it cannot be done because of difficulty. Some non-invasive tests such as urea breath test and stool antigen test detect active infection. These are called active tests. Serology urine near patient tests, that is the breath test, are markers of exposure to H. pylori but do not indicate if active infection is going on or not. These are called passive tests. Prerequisites. Now see, H. pylori patient has hyperacidity. 4 weeks before test, do not take any antibiotics. 2 weeks before test, do not take any proton pump inhibitors, omeprazole, lansoprazole, pantoprazole, rabeprazole, or esomeprazole. Food and drinks. 1 hour before test, do not eat or drink anything, including water. Now, if a patient of hyperacidity or GRD can be kept 2 weeks without PPIs, there is no information whether ranitidine, famotidine can be given, then the patient may not read H. pylori test. So Pap smear, H. pylori breath test is generally done is you blow in a balloon and give that balloon for evaluation. Gastroenterologists say that it is not a reliable test because we know the best test is the tissue diagnosis. So a biopsy from the endoscopy is the diagnostic method. But the labs which do, then they will promise the sky that it is absolutely trustworthy. I have still not done anything, And I don't think I will go in for a urea breath test. My grandchild in Singapore, they had done H. pylori in stool. It was positive. The gastroenterologist said, no, I will not consider this as positive and give treatment. Pap smear. This is one test that we all should advise our patients, sexually active patients, once a year. Because this one test, like microalbuminuria, can tell you 10 years in advance that the patient is going to get cervical cancer. Also, if you are a doctor who's very close to patients and you know the patient has multiple sex partners, then it should be done maybe once in 6 months also. This is the way pap smear is done. A spatula is taken to scrape off the cells at the mouth of the cervix and examined under a microscope. This is the female anatomy, and this is the part that the gynecologist or a trained family physician. In my clinic, I have a Dr. Suman Rao. She is an MBBS, but she has an experience. So she performs pap smear and we never get a failed report. Cervical dysplasia. Cervical cancer has a precancerous stage called cervical dysplasia, that the cells are abnormal. It is the abnormal growth of cells on the surface of the cervix. Although this is not cancer, it is precancerous and it can be treated. It's known as cervical intraepithelial neoplasia or CIN. There are 5 stages of CIN. I'll show you that, but there are 3 categories. CIN1, mild dysplasia. Only the lower 1/3 of cells in the upper layer of cervix are abnormal. CIN2, moderate to marked dysplasia. Up to 2/3 of the layer contains abnormal cell. And CIN3, severe dysplasia to carcinoma in situ. Precancerous cells are in the entire top layer of the cervix. Is used to report cervical biopsy results. CIN describes the actual changes in cervical cell and graded as 1, 2, or 3. Again, mild low-grade changes that usually go away on their own without treatment. Patient has to follow up in 3 to 6 months whether they've gone or not. CIN2 is used for moderate changes. They require treatment. And CIN3 used for more severe high-grade changes. CIN2 and 3 require either cryotherapy or heat therapy. Moderate to high grade can progress to cancer. It's estimated that 5% of CIN2 and 12% of CIN3 will progress to invasive cancer if untreated. In general, it takes 10 to 20 years for CIN to progress to cancer, allowing a significant time for detection and treatment. Faster progression from CIN to cancer requires persistent HPV infection. So who do I suspect for persistent HPV? Multiple sex partners. And in certain cases where there is CIN3, the lab report also recommends to check the patient for HPV, human papilloma virus, if not vaccinated against. And those of you who give vaccines in the clinic, now there are two vaccines of HPV. One is a 4-valent and one is a 9-valent. These are Gardasil. The Serum Institute one is only 4-valent and the 9-valent is costing around 9,000 rupees. And if you can convince your patient and they're willing to take, starting below 15 years of age, saves money. You have to take only 2 and not 3 injections. After 35, giving injections is futile. 2 ways to treat abnormal cervical cells. Excisional treatment. This is a kind of a excision biopsy. Tissue is removed from the cervix and sent to laboratory to be studied. Results can tell whether CIN is present and if so, how severe it is. So this is curative treatment. Ablative treatment, abnormal cervical tissue is destroyed and then there is no tissue to send to the laboratory. How is it destroyed? Either by heat or by cold, nitrous oxide, cryo or heat. Coming to tumor markers, the golden rule that diagnosis of cancer is only by tissue diagnosis and immunohistochemistry. Tumor markers are blood tests which are done to suspect a malignancy in select population, and it guides you to do further tests. They are present in blood and urine of patient that assist in detection and monitoring of cancer. They're quite sensitive to the type of cancer, but not specific. So when we see now different tumor markers, most of them are present in multiple cancers except a few. Ease of collecting the sample because it's a blood test and the test being non-invasive makes it superior to just clinical examination. Nomenclature is always alphanumeric. You have 1 or 2, rather 2 or 3 alphabets and some numbers, at times just alphabets. Used for screening high-risk population. As of now, there is no marker which is to be used for general population. Like even for diabetes, we screen the high-risk population. To support the diagnosis, indicator for disease progression. So a patient of breast cancer is put without treatment because it's terminal stage. A tumor marker 19-9 can be done periodically to understand the disease progression. To monitor remission, if there is remission, I want to continue monitoring that remission is still there. This is in prostate cancers after it is controlled. To detect recurrence, again, when you monitor remission, you detect recurrence and monitor response to therapy. There are no tumor markers, as I said, which are currently recommended for screening of general population. The most likely candidate is PSA as a screen for prostate cancer, that too above 50. There are some circumstances where screening is useful in defined population, not in all. CA15-3 in family history of breast. AFP, alpha-fetoprotein, to screen for hepatocellular carcinoma in patients with established cirrhosis of liver, mainly due to hepatitis B, C, or alcoholic cirrhosis. And at times calcitonin in patients at high risk of thyroid cancer. They will never replace, as I said, tissue diagnosis will never be replaced CA is one. This is a tumor marker which tells you of any tumor in the GI tract. Then you do a colonoscopy and then you check out whether there is cancer or not. One patient of mine underwent a corporate health checkup and they did all tumor markers there, just I think to increase the bill. His CA came positive. He spent a week of sleepless nights. On the colonoscopy, a polyp was detected. So polyp was removed and after 3 months, the CA came to normal. So understand again that a tumor marker may not always show that it's cancer. This is the main use of using tumor markers. Periodic measurement of same marker, if earlier elevated, may assist in demonstrating that effectiveness of treatment, whether it is medical, surgical, or radiation. Over long term, markers are used to identify disease recurrence. Like PSA, patients will keep doing initially after surgery radiation every month, then every 3 months, every 6 months, and every year as the condition progresses and time is more before a recurrence. So AFP is generally for hepatocellular carcinoma and germ cell tumor, but in benign disease, it's massive hepatic necrosis, hepatitis, and maybe cirrhosis of liver. CA15-3, breast cancer, which is the commonest I have given in red. Other possibilities are lung, GI, pancreatic, cervical, ovarian. Ovarian will use CA125. Breast cancer, we will use CA15-3. Again, benign conditions, hepatitis, cirrhosis, benign lung disease, benign breast disease. So if I have a CA15-3 high, mammography suspicious, I may do a MRI breast with contrast to show if there is a lesion which has high vascularity. Nowadays, good sonologists also do a Doppler to see the vascularity, because a vascular lump is mostly malignant unless proven otherwise. CA19-9, pancreatic cancer and biliary tract tumors, acute pancreatitis, cirrhosis, pulmonary disease. But we'll never do that. If I have a suspicious shadow on a CT scan of or MRI, because ultrasound is not very diagnostic of pancreatic pathology since it is lying behind the stomach, I may do a CA19-9 before I go into other tests. CA125, ovarian cancer. And then again, you have endometrial, cervix, lung, breast, colorectal. But then ovarian cancer, we use CA125 or ovarian cancer monitor. Then there are multiple benign diseases. Catecholamines, vinyl mandelic acid. Although pheochromocytoma is not a malignant tumor, but we use VMA to diagnose pheochromocytoma. Patients presents with sudden rise of blood pressure. It can also go up in stress, exercise, medication. There are some doctors who are using VMA in patients of severe anxiety. CEA, colorectal cancers, other GI cancers. So again, if I have a suspicion of colonic malignancy, then I may do CEA. CA125, high molecular weight serum tumor marker, elevated in 80% of patients who present with epithelial ovarian carcinoma. Also elevated in carcinomas of fallopian tube, endometrium, and endocervix. So largely genital tract carcinomas. An elevated level may also be associated with presence of a malignant mesothelioma. So generally more for malignancy, less for benign conditions. Beta HCG, we do to diagnose pregnancy where there is a high risk pregnancy or there is a precious pregnancy. We don't wait for urine test to come positive, but it also diagnosed to test germ cell tumors or choriocarcinomas in addition to other cancers, benign disease pregnancy, and if you have a very high level, normally the normal range is given as per the weeks of pregnancy, gestation period, but a very high value suspect hydatidiform form mole. PSA, prostate cancer, also occurs in benign prostatic hypertrophy, prostatitis, UTI, and prostatic instrumentation. So if you're doing a PSA for a patient, spending money, please check for UTI, because if UTI is present, PSA will be falsely raised. LDH is non-specific in several cancers, including seminomas and other testicular tumors. LDH shows tissue destruction. So if you have a cancer recurrence, LDH may go up to 30,000-40,000 also. Note that for all tumor markers, there will be some false positive and some false negative. Ideal tumor marker should not be detectable in benign conditions, but as you saw, it is detectable. Should be specific to that cancer. Should not be too expensive. Unfortunately, there are no ideal tumor markers and most are restricted to monitoring cancers once they have been detected and diagnosed using other methods. So an ideal tumor marker is like an ideal life partner or ideal patient who will give you respect and will tell you, sir, you are charging less, please charge me more money. Some questions? What is the best time to get C-peptide done with respect to diurnal cycle or food? You require 8 to 12 hours of fasting to do C-peptide. Otherwise, there is no fixed time like a hormone. So overnight fasting is good enough. If type 2 diabetes with normal C-peptide, meaning enough insulin, but insulin resistance, then how does putting patient on insulin help? Very good question. See, this is measuring endogenous insulin, which is not effective. There is insulin resistant. What we are administering is exogenous insulin. And this exogenous insulin does not work on beta cells. It directly works on glucose levels. That is why it helps. Which lab are offering urea breath test? I have seen now 1 milligram, Farm Easy and all, which normally I don't patronize for proper test, but they are offering. What is C-peptide level in type 1 and type 2 DM? Sir, exact values I can't tell you. It depends on the lab and you have to see the reference range. Mukesh Patel, wait for January. You will get a lifelong access to all webinars. How to register for Amara Health will be coming out very soon. After how many days we should repeat the markers? See now, if a patient of prostatic cancer, they have been treated, surgery, radiation, and you are checking, and you're getting all the readings of 0.2, 0.4, and suddenly you get 0.8. You might as well check in a month. Otherwise, the surgeon will advise 3 months, 6 months and all. Should CA 125 be checked in case of large uterine fibromas? See, I had a friend who had a big fibroma and CA125 positive. I checked the literature. This is about 20 years back story. It said that only one case is reported in medical literature that a fibroma was malignant. But yes, no harm in checking. Thank you, Dr. Rajni. So let's meet next week to talk on some clinical topics. Thank you very much.